Hi everyone, welcome back to another video. Today we are covering heart failure, which is one of the most high-yield cardiovascular topics on the UKMLA content map. We'll be going through the background, pathophysiology, how it presents, how we investigate it, as well as some of the crucial management for heart failure. So, heart failure affects approximately 900,000 people in the UK, making it one of the most common reasons for hospital admission. At its core, it is defined as the heart's inability to pump sufficient blood to meet the body's metabolic needs. Now, a really important concept to understand before we go any further is why we classify heart failure using left ventricle specifically. The left ventricle is the main pumping chamber of the heart. It is responsible for systemic circulation, meaning it pumps oxygenated blood out to every organ in the body. It is a high-pressure system. The right ventricle, on the other hand, pumps blood to the lungs, which is a much lower pressure circuit. Because the left ventricle is the primary determinant of cardiac output and therefore organ perfusion, we measure its ejection fraction, the proportion of blood that it ejects with each beat, to classify in grade heart failure. This is what we call the left ventricular ejection fraction, or LVEF. Using LVEF, we classify heart failure into three types. We have heart failure with reduced ejection fraction, where the left ventricular ejection fraction is less than 40%, and this is the most common and well-studied type. We also have heart failure with preserved ejection fraction, where the ejection fraction is 50% or above. In heart failure with preserved ejection fraction, the heart is pumping well but is stiff and cannot relax and fill properly. In the middle, between these two, is something called heart failure with mildly reduced ejection fraction, where the ejection fraction is between 40 and 49%. In terms of causes, ischemic heart disease is the most common cause in the UK, followed by hypertension, cardiomyopathy, valvular disease, and arrhythmias. So, how does heart failure actually develop? It starts with myocardial dysfunction, meaning the heart muscle is damaged or stressed. This leads to a reduction in the cardiac output, meaning less blood is being pumped out per each heartbeat. The body detects this and activates two major neurohormonal systems, the renin-angiotensin-aldosterone system and the sympathetic nervous system. This activation causes sodium and water retention as well as vasoconstriction. In the short term, this is the body trying to compensate and maintain its blood pressure. But in the long term, it backfires. It increases both preload and afterload on the heart, putting it under even more strain and causing further myocardial damage. Essentially, a vicious cycle. Now, this is also where the distinction between left and right-sided heart failure comes from. When the left ventricle fails, blood backs up behind it into the pulmonary circulation, meaning the lungs fill with fluid, which is why left-sided heart failure causes breathlessness, pulmonary edema, and other symptoms. When the right ventricle fails, most commonly because it has been overwhelmed by a failing left ventricle, but also due to things like pulmonary hypertension or right ventricular infarction, the blood backs up into the systemic venous circulation, causing things like raised JVP, hepatomegaly, and others. So, on the left, we have the symptoms and signs of left-sided heart failure. The big three to know are dyspnea on exertion, orthopnea, that is breathlessness when lying flat, and paroxysmal nocturnal dyspnea, where patients wake up in the night gasping for air. On examination, you will also find bibasal fine crackles or auscultation, and patients may have fatigue and reduced exercise tolerance. On the right, we have the classic signs of right-sided heart failure, your peripheral pitting edema, your raised JVP, hepatomegaly, and ascites. In chronic severe cases, you can also see cardiac cachexia from poor organ perfusion. So how would we investigate someone who we think might have heart failure? The first line investigation is BNP or NT-proBNP, and that stands for brain natriuretic peptide. Greater than 400 nanograms per litre means an urgent referral to a specialist is required within 2 weeks. 100 to 400 usually means a routine referral within 6 weeks, and a level of less than 100 means that heart failure is unlikely. The gold standard investigation to confirm the diagnosis of heart failure is an echocardiogram. It measures the left ventricular ejection fraction directly and tells us which type of heart failure we're dealing with, which is crucial when we think about the management. An ECG may show something like a left bundle branch block, atrial fibrillation, left ventricular hypertrophy, or signs of ischemia. A completely normal ECG makes heart failure less likely. If you see a widened QRS, it is worth flagging, as it may indicate the patient needs cardiac resynchronization therapy later. Blood tests such as full blood counts, E's and E's, LFTs and TFTs, as well as iron studies are important, especially the last one. Always make sure to check for iron deficiency in someone with heart failure. It is incredibly common and treatable, and correcting it improves symptoms and outcomes for the patients. So, management. Here, things are different depending on the type of heart failure we're dealing with, and there have been some recent changes. For heart failure with reduced ejection fraction, the current NICE guidance recommends that all patients should be started on all 4 of the following drugs. First one is an ACE inhibitor. Next one is a beta blocker. Next one is a mineralocorticoid antagonist such as spironolactone or eplerenone. And lastly, we also have the SGLT2 inhibitors such as dapagliflozin. So now, how do these drugs actually help? Each one targets a different part of that neurohormonal cascade we talked about. The ACE inhibitors block the renin-angiotensin-aldosterone system and reduce vasoconstriction and sodium retention. This reduces both preload and afterload. The beta blockers reduce the sympathetic drive, slowing the heart and preventing the harmful cardiac remodeling. The mineralocorticoid receptor antagonists, something like spironolactone, they block aldosterone, further reducing sodium and water retention. And lastly, the SGLT2 inhibitors, such as dapagliflozin, promote osmotic diuresis and have direct cardioprotective effects on the myocardium that we are still fully trying to understand. Together, these 4 drugs interrupt the vicious cycle of neurohormonal activation, reduce the workload on the heart, and have all been shown to reduce mortality. For second-line options in heart failure with reduced ejection fraction, ivabradine is used if the patient is in sinus rhythm above 70 heartbeats per minute with a left ventricular ejection fraction under 35%, and only after maximizing the beta blocker, or if the beta blocker is contraindicated. Digoxin is useful in patients who also have atrial fibrillation, but it's important to note that it can actually worsen mortality in patients with sinus rhythm, so we do not use it routinely. Hydralazine and nitrate combinations are used in Afro-Caribbean patients or those who cannot tolerate ACE inhibitors or angiotensin receptor blockers. And then in some cases, we utilize sacubitril valsartan in patients who have a left ventricular ejection fraction of less than 35%. And what we usually need to do first is stop the ACE inhibitors or angiotensin receptor blockers first before using it. So we call it a washout period. Now, here is where one of the most important recent changes in heart failure management comes in. Heart failure with preserved ejection fraction was historically very difficult to treat. For many years, we had no drugs proven to reduce mortality, and management was readily focused on diuretic and symptom relief and treating the underlying causes for the heart failure. NICE and recent trial data support the use of mineralocorticoid receptors agonists now, as well as SGLT2 inhibitors for heart failure with preserved ejection fraction. The SGLT2 inhibitor in particular have now shown clear mortality benefit in patients with heart failure with preserved ejection fraction, which is a significant shift. So while the treatment is not as established as for heart failure with reduced ejection fraction, we now have evidence-based pharmacological options beyond just diuretics. Now, this is the summary for heart failure. The big takeaway are the classifications by left ventricular ejection fraction, understanding why left-sided and right-sided heart failures cause different symptoms, and knowing what we would call the Fantastic Four of heart failure with reduced ejection fraction drugs, alongside the recent evidence now supporting SGLT2 inhibitors in heart failure with preserved ejection fraction. If you found this video useful, please do consider liking and subscribing. It really helps out the channel. And let us know what you would like us to make a video on next. Good luck with your exams, and see you in the next one.